Hey everybody, this is Dr. Medicine RX, and in today's video we'll be discussing about hyperlipoproteinemias. So primary hyperlipoproteinemias are of 6 types. So type 1, type 2A, 2B, 3, 4 and 5. So coming to the first one, type 1, it is familial hyperchylomicronemia or primary hyperlipoproteinemia. Here the defect lies in the deficient or abnormal levels of lipoprotein lipase and ApoC2 defect. Coming to clinical features, so since this is a familial disorder, there is going to be childhood onset, and the type of xanthomas seen here are eruptive xanthomas. Lipemia retinalis can occur, and it is associated with hepatomegaly, pancreatitis. There is going to be a horrible screaming type of abdominal pain. Coming to investigations, since this is hyperchylomicronemia, there is going to be increased levels of chylomicrons and increased levels of triglycerides. Coming to prognosis, the lifespan is normal. However, because of pancreatitis, death can occur, but there is no increased risk of coronary artery disease. Management is by diet control. Coming to type 2A, also known as familial hypercholesterolemia. Here the defect lies in the LDL receptor. And coming to the clinical features, it is less common. The types of xanthomas seen can be palmar, tuberous and plain types. And it is associated with hepatoma, obstructive biliary disease, porphyrias, hypothyroidism, anorexia, nephrotic syndrome and Cushing's syndrome. Coming to investigations, there is going to be increased levels of LDL because the receptor defect is that of LDL. Then there is going to be increased cholesterol level and also normal levels of triglycerides. Coming to prognosis, there can be myocardial infarction because of premature atherosclerosis of peripheral and coronary arteries. Management, early intervention helps in improvement. Bile acid sequestrant, statins and niacin are effective. Coming to type 2B, it is also known as familial combined hyperlipidemia. Here the defect lies with the LDL receptor as of type 2A, but here there is going to be additional increase in ApoB protein. Coming to clinical features, this is commonest of the hyperlipoproteinemias, and the type of xanthoma seen can be eruptive, tendinous and plain. It is associated with nephrotic syndrome, Cushing's syndrome and diabetes mellitus. And on investigations, there is increased levels of LDL and also increased levels of VLDL, increased level of cholesterol and also triglycerides. Whereas in type 2A, only the LDL and cholesterol levels are increased with normal triglycerides. Coming to prognosis, premature atherosclerosis can cause myocardial infarction, but early intervention is very useful. Statins, niacin and fibrates can be given. Coming to type 3, it is also known as familial dyslipoproteinemia or remnant particle disease or the beta disease. So here there is a defect in ApoE. So ApoE abnormality leads to impaired hepatic clearance of the remnant particles, so leading to increased levels of remnant particles. On clinical features, it is seen in the 4th and 5th decade. However, of all the types of hyperlipoproteinemias, it is rare. And plain xanthomas are characteristic of type 3, but tuberous, tendinous and tubo-eruptive type of xanthomas can also be seen, and it is associated with diabetes mellitus, gout and obesity. Coming to investigations, there is increased levels of chylomicron remnants and increased intermediate density lipoproteins, and also increased levels of triglycerides and increased levels of cholesterol. Prognosis, so here as well, atherosclerosis of peripheral and coronary arteries can cause MI, but management is by diet modification as well as with statins, niacin and fibrates. Next, coming to type 4, it is also known as familial hypertriglyceridemia. Here the defect is not well known. However, there is increased levels of VLDL that are associated with glucose intolerance and hyperinsulinemia. So coming to clinical features, the onset is in early adulthood and it is associated with eruptive xanthomas as well as type 2 diabetes mellitus, obesity, alcoholism, lipodystrophy, monoclonal gammopathy and uremia. On investigations, there is increased levels of VLDL, they are very much increased, and also moderately increased levels of triglycerides. Prognosis, it responds to lifestyle changes. However, premature atherosclerosis can cause MI, and management is by diet modification, statins, niacin and fibrates. Coming to type 5, it is also called as familial combined hypertriglyceridemia or multiple lipoprotein hyperlipidemia. Here the defect lies with ApoA5. Coming to clinical features, it is less common. It is seen in adulthood and it is associated with erythroxanthomas and diabetes mellitus. Prognosis, the patients may succumb to pancreatitis or to premature atherosclerosis. Management is same with niacin, fibrates and statins. Coming to secondary hyperlipidemias, they occur as a result of a constellation of causes, but increased cholesterol levels are primarily seen in primary biliary cirrhosis. But increased cholesterol with increased LDL is seen in nephrotic syndrome, hypothyroidism, and certain drugs such as thiazide diuretics, and some other causes as well. And increased triglycerides with VLDL levels is seen in chronic renal failure, diabetes mellitus, obesity, and gout. Whereas increased triglycerides with increased HDL levels are seen in glycogen storage disorders and patients on OC pills. Thank you. Subscribe for more.